screening to detect, some of the hidden conditions. So we all know that we cannot talk about all this in this sitting. So I've tried to focus on some selected interventions. But first of all, let's talk about recognizing and responding to the dangers, because it is only when you are able to recognize, make diagnosis, that you'll be able to respond, and then the baby's life will be saved. One of the things that these babies present with is severe respiratory distress. If you are not able to, or maybe we teach our nurses as well, these things: chest indrawing, grunting, tachypnea, and then when the SpO2 begin to drop to like less than 90%, we need to, respond. And what are some of the causes of this respiratory distress? Respiratory distress is just, one of the symptoms and signs that we can pick on this baby. So we must be able to think cardiac causes, respiratory causes, upper and lower, and, majorly in the lower is the RDS for the preterm babies, pulmonary hemorrhage, pneumothorax, and so on. Then issues with their central nervous system, hematological problems. If a baby has polycythemia or he has severe anemia needing transfusion, it will present in severe respiratory distress. And if you don't diagnose that anemia and transfuse, no matter how much oxygen you give, that baby will still die. So this is what we are saying, that we must be able to recognize and respond appropriately to these danger signs. Some of it can even be from metabolic acidosis, hypoglycemia. Some can even be outrightly sepsis, hypothermia, or hypovolemic shock. But when we also talk about sepsis, neonatal sepsis, we should also know that the baby will present in a non-specific way. Some may stop feeding, the ones that have been feeding before. The temperature instability is there. There may be hypothermia. There may be, the temperature may even be normal. So we must have, high index of suspicion. And then something I learned in the action trial was, showing us videos of all these specific conditions. When a baby has neonatal sepsis, the baby, sleeps like a log of wood. He's not moving. You tap, he's not even responding. Think sepsis. So these are some of the things that I said I should point out in that place. For preterm birth, we are more afraid of respiratory distress syndrome, the most important cause of mortality in preterm infants, and is a condition primarily from the CNS immaturity, pulmonary immaturity, surfactant deficiency resulting in respiratory insufficiency. And the modern aim and objective, of treatment of RDS is to maximize survival while minimizing air leak and bronchopulmonary dysplasia. And so placed side by side, our national guide and the European guidelines for management of RDS. This was written by a panel of experienced European neonatologists and experts, perinatal obstetrician. And the update as at year 2023 summarized that we should be able to predict the risk of preterm delivery. We should be able to appropriately, transfer this mother while the baby is still in utero to a perinatal center. We must appropriately and, use antenatal corticosteroid, and it must be timely. And then long protective management, such as non-invasive respiratory support from birth, must also come to our mind. And we must use oxygen judiciously, because we know now oxygen is a drug. You don't just give oxygen. Gone are the days when our nurses will just look at the baby and say, full oxygen, just give oxygen. No, now you must check the saturation level of that baby and then decide whether this baby needs it or not. Early surfactant administration, caffeine therapy, avoidance of intubation and mechanical ventilation where possible. And this may help to reduce incidence of chronic lung diseases. Now, for talking about appropriately and timely use of antenatal steroids. A Cochrane review of 21 randomized controlled trial involving over 4,000 neonates reported that even a single course of steroid administered between 26 to 34 weeks gestation will reduce neonatal death by 31%. And this has further been, buttressed by the Action trial, Action 1 trial. I was actually part of that WHO work. This work was performed in 29 hospitals across Bangladesh, India, Kenya, Pakistan, and Nigeria inclusive. It was a large multi-center, multi-country research, and they have reiterated that using 6 milligrams at 12 hours interval times 4 doses, is beneficial to the preterm neonate, and it will reduce respiratory morbidities and also, reduce mortality in these babies. And the WHO Action 3 trial is currently ongoing to compare the use of placebo versus betamethasone and dexamethasone. And this is being looked at in late preterm. Now, another thing we need to do to be able to avert neonatal death is this practice of non-invasive respiratory support. And this has to be from birth. This is evidence-based that using CPAP is protective to the lungs. And CPAP may be considered immediately after birth, in an infant less than 32 weeks gestation, with or without respiratory distress. If he even has RDS, the lungs are collapsing. By the time you start the pressure from 6 to 8 centimeters of water, it helps to reopen the alveoli, and it prevents further collapse, and it can even recruit, other adjacent alveoli. So immediate CPAP or delivery room CPAP is now advocated. And bubble CPAP may be considered rather than other pressure sources. Some people use ventilator CPAP, but this has also been reported to have a bit of baro and volu trauma. So bubble CPAP is advocated, and it's been found to decrease treatment failure and also lower the incidence of BPD. These are some of the gadgets. To my left is the diamedical CPAP. This is one we use in my center. And we also see, some of the nasal prongs. And we also have other forms of CPAP, the Pumani, the Fisher and Paykel, then the Vayu, bubble CPAP, and so on and so forth. Another low-cost intervention that the WHO admonished us to do is, using caffeine. The caffeine for apnea of prematurity study, that is the CAP study, confirmed that standard dose of 20 milligrams per kg loading dose and 5 to 10 milligrams per kg per day maintenance results in less need for respiratory support. Although we may say caffeine is expensive, but when compared to other forms of theophylline, especially the aminophylline that is so cheap, aminophylline maybe is 100 naira or 200 naira, it may be better to use caffeine, and caffeine is recommended because in looking at the side effect of respiratory aminophylline sometimes. Although we may say caffeine is expensive, feed intolerance, because when compared to other monitoring, how many of us can do, especially serum levels of the drugs that we are giving? Aminophylline is one of the drugs that you must do, the serum level to rule out toxicity. So when this occurs, babies begin to have better tolerance caffeine, and caffeine is recommended because looking at the side effects that all these will culminate. Although we may say caffeine increased feed intolerance, and sometimes when people are in a hurry, and many of us problems, especially serum levels of the drugs that we are giving. But caffeine has been found to be safe, does not need any TDM. And the outcome is that there's decreased need for mechanical serum level to rule out decreased incidence of BP. So when this it may be better mortality in these babies that they use it for, and then eventually neurodevelopmental disability is reduced. Of course, we should not forget the issues of hand hygiene. It is life-saving in the NICU. The NISON president and her team earlier this week discussed the issue of infection control in the NICU, and I was able to, give a summary of one slide about what the WHO says about 5 moments of hand hygiene from that lecture. So we should wash our hands before patients contact, before a procedure,